So guys, let's finish up with our management of hyponatremia. Draw this picture once more. So we said that we introduced the term dilutional hyponatremia, and we said that conditions that give you dilutional hyponatremia are your fluid overload, states or medical conditions, and those conditions are things like heart failure, liver cirrhosis, nephrotic syndrome, malnutrition, or same, portal hypertension, and many others. So these conditions, they give you fluid overload. So how does hyponatremia result from fluid overload states or fluid overload medical conditions? So what happens is, when you've got fluid overload, it means you've got a lot of water that is in the plasma or in the intravascular, so much water there. Now, when you've got a lot of water in the intravascular, what happens is that the hydrostatic pressure increases, and when it increases, it forces water into the extracellular space, or the extracellular fluid, or the interstitial fluid. And when that happens, remember, you have sodium that is in here. This sodium is very important to make sure that the cell maintains its take pressure, doesn't collapse, or it doesn't burst. So that's why we talk about osmolality across the bilipid layer. It must always be under check and controlled. Now, the water that is here, the water that is in the extracellular space, that is being pushed by the hydrostatic pressure into the extracellular space, it comes and dilutes the sodium that is in here. Remember, we have an opposing force, the oncotic. The oncotic will try to take some of the water back into the intravascular, but it won't take all the water. That's why these patients, they end up with edema. So these patients, they end up with edema. All of them, they end up with edema. It's because they've got an increased hydrostatic pressure, and the oncotic is not coping with this sudden increase of water in the extracellular space. So they get edema. Now, you come in and you have got these patients, and what you do, you take a sample, you take blood to the lab. The blood that you take to the lab, the amount of this water that has been pushed into the extracellular fluid has diluted the sodium. So the sodium that is going to show on that sample that you took to the lab is going to appear as if it's low hyponatremia, because you got dilution. The sodium in the extracellular got diluted because of the excess water that was pushed out by the hydrostatic pressure into the extracellular fluid or extracellular space. So these patients, if you can check how the hyponatremia occurs, it's not because they have lost any sodium, but it's because the sodium that is there has just been diluted, right? That's one mechanism of getting a dilutional hyponatremia. So these conditions, this is how they give you dilutional hyponatremia. Now let's talk about, we also know that hyperglycemia, mannitol, glycine, they also give us dilutional hyponatremia. But let's look at how does that happen. So we're gonna go back to our drawing again. Our cells, intracellular, extracellular, fluid, plasma. So I'm saying your hypertonic, so basically here we're explaining how hypertonic hyponatremia occurs. We know that hypertonic hyponatremia also gives us a dilutional hyponatremia, but what we're interested in, we want to know how does it happen. So with hypertonic hyponatremia, you have an osmotically active substance in the intravascular, and we said it can be things like hyperglycemia, it can be glycine, it can be mannitol. So what these do, because they are osmotically active, they tend to pull water from the extracellular fluid into the intravascular. And when that happens, the sodiums that are here will remain, but this environment now is gonna be hypertonic. It's gonna be hypertonic, and because it is now hypertonic, water will start to be taken from the cells into the extracellular space. Now what has happened is that you have diluted the sodium once more, but look at the direction. Now you have diluted this sodium in the extracellular fluid. You have diluted this sodium, but the water is coming from the inside of the cells this time. It's coming from the inside of the cells this time. Unlike in these conditions whereby the water was coming from the other direction. So the water is coming from that side. Now this water is pulled, and then that's how you get your hypertonic hyponatremia. How do you manage these conditions? So with these ones, the best way to manage these ones is just to give them diuretics. That's the best way of managing their hyponatremia. Because remember, they don't have a true hyponatremia, they have a dilution. So their hyponatremia is due to a dilution. So the minute you take away the excess water, then the remaining sodium, so you're going to get a true value of the concentration of the sodium in that extracellular fluid, right? With these ones, what you want to do, it's more or less the same, but you want to correct this, because this is the offending. Just like there, as much as you're going to give the patient diuretics, get them out of heart failure and all, but the diuretics are the mainstay there. In this case, you're gonna give diuretics as well, but make sure that you also correct the hyperglycemia, the glycine, stop the mannitol, and that kind of a thing. So mainly with dilutional hyponatremia, always think about diuretics in general, right? Okay, now let's quickly talk about depletional hyponatremia. So depletional hyponatremia So with depletional hyponatremia, what you have there, you've got an actual loss now of sodium and water, right? And when it comes to losing water, the patient can be sort of like hypovolemic, or they can be euvolemic, or they are hardly overfluid, these ones, or overfluid loaded. They hardly have fluid overload, if I may say. Let me put it that way rather. So they hardly have that. So these patients are patients that have got, so they've lost their sodium through be it your GIT causes, your renal causes, your skin losses. So they've got an actual, the important thing is that they've got an actual loss of sodium and water. So with them, you just give them the normal saline, and the fluid in the normal saline will correct the loss of fluid, and then the hyponatremia will be corrected by the sodium that is there. But the management of these conditions, at my level, what I've managed is mild to moderate hyponatremia. I've never have to manage severe hyponatremia. There's only one patient that came with seizures with hyponatremia who was diabetic, but it was just one episode, and after giving fluids, the patient never had problems again. So I think that was the only severe one that I've seen. But I mean, a patient who's in coma, who's unresponsive, who's very low GCS, that kind of a patient, and then when you check they've got hyponatremia, I mean, that patient will need to be managed by specialists, the help of physicians. I'm not at that level of giving patient hypertonic saline with the Lasix and blah blah blah. I'm not there yet. So yeah, guys, this is like the basics of hyponatremia and managing hyponatremia. Hopefully one day when I'm specialized, I'll come back with more details and all of that. I hope this helped, and yeah, and remember how we diagnose renal losses. We check the sodium. If the concentration of sodium in the urine, if it's more than 20 millimoles, then we know that we are losing our sodium through urine. But if we've got hyponatremia, but our sodium concentration is less than 20 millimoles in the urine, then it means we're not losing the sodium through the urine or through the kidneys, but it can either be GI or skin losses, or those are the main ones. Okay, thank you guys.